You make tough calls when caring for acutely ill and injured children. Join us for strategy and support through clinical cases, research, and reviews, and best practice guidance in our ever-changing acute care landscape. This is your Pediatric Emergency Playbook.
Welcome to the Playbook. I'm your host and coach, Tim Horechko. Any injury in the hand, regardless of age, is a high-risk presentation. Findings can be subtle, and if we get it wrong, your patient may end up with long-standing consequences. Today, we'll talk about fractures of the hand in children, from the phalanx to the metacarpals. In another episode, we'll talk about injuries to the wrist and forearm. Starting distally with the phalanges and the simple Tuft fracture, we'll work our way down to the metacarpals and the dreaded named comminuted fractures. First, some general considerations in hand injury. They're common and can be missed. Think of children and hand injuries as a triple jeopardy. They're active and still learning to coordinate themselves and to interact with the environment. Their bones are tricky, fragile physes and confusing ossification centers. Since the physis, the growth plate, is not yet mineralized, it's not as structurally sound as the rest of the bone, which makes it a common site to absorb the energy of impact. If we get it right, if we diagnose early and splint, reduce, or operate on time, there's a great potential for healing. If we don't, we can see differential healing. The physis and diaphysis heal and grow at different rates, accentuating the initial displacement. It is really all about the physis. In Greek, physis, physis, or ta physika, literally means nature or growth, and that's where we get all the words that mean the natural physical world, like physics, physical, physician, all relating to nature. In fact, Socrates would speak of ta physika, the natural world of flora, fauna, and then nomos, the things that we name and categorize ourselves as humans, our human world, so laws and customs. In fact, ta physika would be nature, and nomos would be nurture. So there you go. Physis, in our usage, comes from the word in Greek physein, to grow, and so now you know why we call the physis the growth plate. When we talk anatomy, we'll use the physis as our reference point for the rest of the long bones. On top of the physis is the epiphysis, the epiphysis, the epiphysis. Just like epidemiology is epi, upon, and demos, the people, the study of what is upon the people, what affects people, epidemiology. We have the physis, then distal to that is the epiphysis. The physis eventually calcifies and metamorphoses into the metaphysis. So on the opposite side of the epiphysis, you have what is beyond the physis, so the metaphysis. Everything else is the diaphysis. Dia, in this case means between the physes. So distal, we have the epiphysis, then the physis, then between the two physes, we have the diaphysis. The metaphysis is just another name for the region that metamorphoses from the physis to the metaphysis. As you can imagine, boys break their hands much more often than girls, with about 75% of fractures of the hand occurring in boys. Most of the fractures will be in the school-aged group. The others will happen before ossification. As an example, in the toddler and the young child, luckily they'll have more soft tissue injury. Now that we have a bit of an overview, let's go distal to proximal and cover the fracture patterns and treatment that we need to know. A child gets a finger slammed in a car door or a heavy object that falls on the distal phalanx. You'll see a crush injury to the fingertip, and that can range from a little swelling to ecchymosis and possibly an open fracture. If you're a toddler or a preschooler and you just happen to have hand injury on your agenda for the day, this is probably the one you'll get. Up to 75% of hand fractures in this age group are tuft fractures. They're called tuft fractures because the cluster of bone at the very tip, the tuft, is crushed. On the one hand, they can look pulverized, and that would make anyone kind of upset just looking at it. But on the other hand, the distal phalanx doesn't serve any weight-bearing role, and they aren't really integral to the structure of the hand itself. They do very well with conservative management. If there's a concomitant laceration, then by all means, anesthetize, irrigate it, and treat it like a laceration. These tuft fractures are not treated like open fractures. They do very well. You can put them in a clamshell plastic finger splint or even a malleable cushion splint, mostly for comfort. But remember, anything that you put on a toddler or a preschooler is coming off. Officially, they should be in the splint for 2 to 3 weeks, but again, good luck with that. Antibiotics are not necessary. In a double-blind, randomized, placebo-controlled trial, Stevenson et al. Found that there was no difference in infection between those who received and did not receive antibiotics for their tuft fracture lacerations. All subjects did receive careful, quote-unquote, wound toilet, which sounds odd. They just really meant that they took really good care of that wound. Analgesia, wound care, and follow-up. Even with a primary care physician, it's all that is really needed. Here's another classic slam door injury with a bit of a wrinkle. The Seymour Fracture. It's a hidden, open fracture of the distal phalanx. Hidden? How could a fracture hide from you? Well, the nail bed is avulsed, and it pops out from under the cuticle and covers up the laceration. It happens when you have forced flexion of an extended digit. It could be your finger or your toe. Now, this happens only in children because the growth plate is involved. Since the growth plate is the weakest portion of the fulcrum, it breaks between the extensor tendon on the dorsal side and the flexor digitorum profundus on the volar side. The mechanism rips right through the germinal matrix of the nail bed and everts the proximal portion of the nail up and out of the nail bed, essentially covering up the open fracture. Since the digit may be bloody and edematous, you may not totally see it unless you really look carefully and realize that, that nail looks especially long. Wait a minute. If I perform range of motion, it hurts and the nail bed is flapping around in the breeze. On plain films, on the AP view, you may just see what looks like a normal or even an accentuated growth plate, but you'll see the displaced fracture on lateral view. It'll either be a small Salter-Harris 1 or 2. The general approach to Seymour fractures is to treat it like an open fracture. Everyone would agree that irrigation and prophylactic antibiotics are indicated. Traditionally, these all went to the OR to remove the nail and reduce the fracture with a Kirschner wire. There's some evidence now that these can be managed in the ED non-operatively. If you can get proper analgesia and anesthesia, you can clean the wound and relocate the nail bed and reduce and splint the fracture. In the Journal of Pediatric Orthopaedics in 2019, Lin et al. Report a retrospective series of Seymour fractures. The mean age was 10 years, And most of the 65 cases in the series were boys. 89% were initially managed in the ED, 11% in the OR. Of the 58 patients managed in the ED, only 4 required an unplanned operation because of redisplacement later. The authors conclude that the initial reduction in care in the ED is safe and effective. I would just say that if you feel comfortable, go for it. You're going to do everyone a favor by trying to reduce it initially. And since infection is a big concern, you're either washing out that nail bed and replacing it or just taking it off. Now, I prefer to treat this like a combination nail bed avulsion and fracture, which it is. I treat both and get the patient the follow-up that he needs. This is a strategy that is especially helpful if you don't have orthopedics at your beck and call. One thing to remember, though, is you don't want to replace that nail bed between the avulsed fracture fragment and the rest of the bone. So this is only a replacement in the ED if it's a very straightforward case. Now, remember, urgent follow-up is within a week or so. So as long as you wash it out, reduce what you can, splint and refer, you're going to be in good shape. Use your best judgment based on the resources at hand. If the Seymour fracture is what happens to little kids, then the Mallet fracture is its older sibling. It's the same mechanism. An actively extended finger is forced into flexion. The extender tendon pulls off a fragment of the epiphysis, and you end up with an intra-articular fracture. In the Seymour fracture, there is still a growth plate, so the relatively weaker growth plate takes that hit. In a Mallet fracture, the growth plate is already fused. This is an older child, and so the forces extend into the joint. Adolescents are a tricky bunch because of their variable fusion of their growth plates. The conservative approach is to treat Mallet fractures in adolescents like a Salter-Harris 3 or 4 involving the joint. In general, if the fracture involves less than a third of the articular surface, it's usually stable and doesn't necessarily need OR time. A small fracture can be dealt with by splinting. I just mentioned this if your orthopedic consultant doesn't rush this intra-articular fracture to the OR, it's okay. Fracture fragments larger than 50% of the articular surface, they're always unstable and they're going to need surgical fixation. If your patient is lucky enough to only need a splint, then they need to treat that seriously. Luckily, these are older children with mallet fractures and hopefully more cooperative. Splinting will work, but it must be strict. No peeking. All right, we are finished with the distal phalanx. Moving proximal, we have our middle phalanx and a fracture that is also only seen in children. Why? Well, remember, it's all about the physis. When there's a fulcrum force applied to the middle phalanx in a child with a growth plate, strange things can happen. The growth plate, of course, is the weak spot and where we get the initiation of the fracture, but the epiphysis can then be thrown in all kinds of directions. We're talking now about phalangeal neck fractures. There are 3 types of phalangeal neck fractures, all with multiple subtypes, but all we really need to know is that the epiphysis can be broken right off at the growth plate, and that piece can be translated volar, dorsal, or even turned upside down. They do tend to displace into extension and dorsally, and if you don't reduce them, remodeling causes a volar spike to form, preventing flexion at the joint, which can be disabling. To make sure not to miss these phalangeal neck fractures, you may have to get true lateral x-rays of the finger without overlap of the other fingers. If not reduced properly, there's a risk of malunion. These really need closed reduction as soon as possible. You can give it a try, but even if you're successful, the patient should still be seen by an orthopedist or hand specialist soon after. Since children heal so quickly, if there's a delay to reduction by a week or more, they may start to form a callus. At that point, not only is closed reduction off the table, but also operative management becomes more difficult. In short, distal fractures of the middle phalanx, phalangeal neck fractures, need careful closed reduction as soon as possible. They do well if attended to, and poorly if neglected. Let's stay with the middle phalanx a bit more. It needs some love. The middle phalanx is like the middle child of the finger bones. It gets ignored a lot. Except when it really wants attention, it gets it in a spectacular way. Let's talk about the central slip and the volar lip. The volar plates are ligaments found on the volar or palmar surface of the metacarpal phalangeal joints and the interphalangeal joints. They help to prevent hyperextension. The PIP, the proximal interphalangeal joint, is a synovial hinge joint, like its brothers and sisters in the rest of the hand. The volar plate stabilizes that joint from the palmar or volar side. This ligament has extensions into the periosteum that anchor it from the proximal phalanx to the middle phalanx. The extensions are called checrine ligaments, and they're like little tentacles that fasten and help stabilize the joint under normal conditions. But when they're stressed, they can pull off the bone and cause an avulsion fracture. This is called a volar avulsion injury, and for sure you've seen this before. It's that little chip of bone off the proximal epiphysis of the middle phalanx. The patient will come in complaining of a hyperextension injury. He'll have tenderness over the volar PIP joint, lots of pain on passive extension of the finger. He may have lost pinch strength as well. X-ray will confirm the volar avulsion injury. So, analgesia, and you can start with a specialized splint that prevents extension. It's a small finger splint that keeps the interphalangeal joint at 20 to 30 degrees of flexion. The idea is that you don't want more stress on the avulsed volar plate and fragment. There's quite a bit of variability in the management of these fractures, and you'll definitely want to involve your orthopedic or hand specialist to avoid long-term stiffness, subluxation, or loss of grip strength. The point here is that just because it's a small little chip fracture doesn't mean it's not a big deal. The running theme, as we've mentioned, is that hand injuries are high risk because letting them heal in a malposition will have lasting consequences. Make sure you talk to someone or have tight follow-up. Most of these will not need surgery. They're going to fibrose and restabilize over time, but the phone call, the warm handoff, or the close follow-up is important because these volar plate injuries need to be monitored to make sure that that fibrosis is what we expect to happen in a controlled, functional way. After a week of strict splinting, patients will need early range of motion exercises, they'll need physical therapy, and they'll need serial exams over weeks. The patient and his family need to know that this is just the beginning of serial exams and a lot of homework on their part. This is not an injury to slack on. What about the other side of the finger? The dorsal counterpart of the middle phalanx injury is the central slip injury. Now, this may be a little bit more anatomy than you really want to hear right now, but we all need to hear it. Buckle up. There are 3 muscles that help to extend your finger: the extensor digitorum communis, the lumbrical muscle, and the dorsal interosseous muscle. Let that seep in a second. There's 3 muscles: the dorsal interosseous, the lumbrical, and the extensor digitorum. Okay. The cool thing is that all 3 portions of the extensor digitorum communis will come together into a central slip dorsally that covers the proximal phalanx and inserts into the dorsal base of the middle phalanx. It's a very effective extensor pulley mechanism. But there's a catch. There's always a catch. There are lateral bands from the interosseous muscles that form a network via the triangular ligament with the central slip tendon. The central slip, of course, is medial, and the rest of the network is meshed around it. If you have a hyperflexion injury and snap that central slip, bad for you, because first, you lose extension power, but secondly, and this is what really causes the trouble, the lateral bands now have unopposed tension, and they resume a permanent position that changes the way the pulley system extends the finger. Instead of a balanced pulley that gives you extension from the central slip and stabilization from the lateral components, you now have only the lateral components acting as a pulley, and they pull from an abnormal position, from a volar position. You end up with a PIP joint stuck in flexion and a DIP joint stuck in extension. A total breakdown of function. This is called a boutonniere deformity, the buttonhole deformity, because the loss of your extensor power from your central slip plus the overpowering of the lateral forces will cause the proximal phalanx to push through the extensor hood, like a proximal phalanx button through a ligamental mesh, and it gets stuck in this abnormal position. Check the show notes for a visual, but in short, the existential balance of your finger extensors is destroyed. Your extension yin and yang is disrupted, and you end up with a gross deformity. You'll remember back to this moment, and you'll think, aha, central slip. And that's all I really want you to know. Chronically, you can get this as an adult from degenerative diseases such as rheumatoid arthritis. Traumatically, if you're a young person who has a forceful blow to the dorsal side of a flexed finger. So in sports, someone steps on your hand while they're trying to get up off the ground, maybe in soccer, for example. Clinically, you'll see the proximal interphalangeal joint flexed and the distal interphalangeal joint extended, and on X-ray, an avulsion of the dorsal rim of the middle phalanx. Rarely do you have the entire central slip ripped off. Usually there's some residual structural integrity, and if there is, if the function of the central slip is intact, these can be splinted and really treated similarly to volar plate injuries. But there's another catch. It can be hard to tell. Now, to help you out at the bedside, you can use the Elson test to determine how much central slip power you have left. Normally, your central slip extension is far more powerful than what the rest of the extensor mechanism can do. Your PIP extension power is much stronger than your DIP extension power. And that makes sense, right? If your PIP extension is now out because of a ruptured central slip, then the relative strength of your DIP will actually show up clinically as stronger than your PIP. To isolate your DIP, you have the patient place his palm on the edge of a table so that the PIP joint is flexed at 90 degrees. Then you have the patient extend the DIP in this position against resistance. Normally, you really shouldn't see much since your major power should be at your PIP with the central slip. But if your central slip is out, then you'll get some great extension against resistance by your DIP. The Elson test. In other words, a normal central slip test will show weak DIP extension because you're forcing the PIP into 90 degrees flexion and the central slip is doing all of the work to extend and you're blocking it. If the central slip is out, the unopposed lateral ligaments take over and give you more DIP extension than you really should get. So, more DIP extension power against resistance is actually a bad thing and a positive Elson test. Like the other finger injuries, there will be a lot of judgment used in the treatment. The spectrum will be from splinting the PIP joint in full extension to allow for proper healing all the way to pinning. Since we can't provide definitive care in the ED for these injuries, no matter what, they need at least close follow-up. It's important to involve your specialist early. If you have access to a hand specialist, go with that, or with an orthopedist, or an urgent follow-up with a primary care physician to coordinate care, and as warm of a handoff as possible to avoid delayed care. We're leaving the middle phalanx now and venturing proximal to, the proximal phalanx. Now we're getting into some multidimensional stuff. At first, you may see a fracture of the proximal phalanx and say, hey, this is a simple enough clean break. It's right through the proximal phalanx. Closed reduction, maybe an ortho consult for percutaneous pinning. I got this. Let's take a step back for some perspective. Most fractures of the phalanges or metacarpals will be minimally displaced and they'll be stable. The periosteum can be a great hinge for reduction in children. We use that often to try to get them back in line. If you can realign them well, they're going to heal well and they won't really need more than 4 weeks in a cast. If the hand fracture needs perfect alignment, then percutaneous pinning is the best way to go. In fact, most pediatric hand fractures will either need closed reduction or pinning. Rarely do they need invasive surgical techniques like open reduction. If there is any intervention, then it's the Kirschner wires, the K wires, that are placed fluoroscopically through the skin and soft tissues into the bone to assure proper alignment. Of course, if a K-wire is placed, it has to be protected by a cast or a brace, and they're temporary. They're only in there for a few weeks. They're often removed pretty routinely in the office, and even little children do well without sedation. This leads us back to our discussion about proximal phalanx fractures, because they're a little trickier than on first glance. The X-ray, of course, is helpful to determine where and how the phalanx is broken. The third dimension here will be your special physical exam technique to look out for possible rotational abnormalities. There's even a fourth dimension here, which will be your best judgment. Even bland-looking fractures that don't look too displaced can have substantial rotational deformity, especially in the proximal phalanx. The rotational dimension won't be visible until you look for it specifically. To test for this, have the patient point his palm to you and his fingers flexed towards his palm. All of the nail beds are now facing you. Each fingertip should be in line with the next, free of rotation. All fingertips should be pointing in an imaginary line to the child's scaphoid. If any nail bed is off or the fingertip is not pointing to the scaphoid, well then, my friend, you have a rotational deformity on your hands. And we can't ignore these. They must be addressed with K-wires, or the patient will heal in malposition and forever suffer problems with grip and flexibility. If the proximal phalangeal fracture is stable and there is minimal displacement and no rotational deformity, then buddy taping can actually be the way to go. You can place gauze between the digits to pad and prevent maceration of the skin, which of course can lead to infection. You tape above and below the fracture and teach the family to do the same, changing the taping when it gets too dirty or too soggy. Typically, this is done for 3 to 4 weeks. If there is an oblique or spiral fracture of the proximal phalanx, you'll usually need more rigid immobilization, and you could put the patient in either an ulnar gutter or radial gutter splint or cast. Remember, though, that a splint can't hold a fracture to length. It only prevents flexion or extension or ulnar or radial deviation. If you need to keep that fracture fragment at length, then the fracture needs operative fixation. Before we leave the subject of proximal phalanx fractures, I just want to mention a specific type. Actually, it's the most common type of proximal phalanx fracture in children, the extra-octave fracture. It's a hyperabduction of the fifth finger, and you end up with a Salter-Harris 2 fracture. So a fracture involving the physis, the growth plate, and a fracture fragment distally. The ulnar collateral ligament is breached as well. You end up with a poor kid looking like someone tried to break off his little pinky and it's just hanging to the side. Now, it has a really bougie term, the extra-octave fracture, because if you're playing the piano or harpsichord or whatever, and you're trying to hit that faraway note with your pinky finger, it looks like you're trying to get to that higher octave, but nope, you broke your finger. So it's not a great term. No one's breaking his finger playing the piano, but it's a gross deformity of that small finger, and I guess it's sort of a whimsical term for it. Regardless, this is the kind of fun fracture for us to take care of. Give the child some good analgesia and potentially an ulnar nerve block. Make sure their pain is under control. You can then place a pencil in the web space between the 4th and 5th digits, really pushing in proximally to seat it nicely in the web space to get ready to use that pencil as a fulcrum point. With your pencil or pen or whatever you got firmly in place in that web space, you can then adduct the 5th digit, reducing the fracture. Get post films, make sure it's an acceptable reduction, give them more pain medicine, and if all is aligned, you can place some gauze between the digits, buddy tape them together, and put the hand in an ulnar gutter splint or cast, and give them follow-up. On to fractures of the metacarpals. In children, most of them will be in the 5th metacarpal neck, the so-called boxer's fracture. In general, metacarpal fractures do well even with some angulation. We can accept more angulation the further you are away from the thumb. The thumb we'll talk about separately because, well, it's your most important finger. Starting at the 2nd metacarpal, we can allow only 10 degrees of angulation. Next, 20 degrees. Next, 30 degrees. And finally, on your 5th metacarpal, you can allow up to 40 degrees of angulation. So start counting on the 2nd metacarpal and say 10, 20, 30, 40, and you've got it. Comes in handy because despite your best systemic analgesia and hematoma block, it's hard to get these to stay once they're reduced. If you're within these parameters, then splint initially and cast later. That's all you really need to do. Otherwise, it's time to involve your orthopedic colleagues early. One caveat here is if you see rotational deformity. Remember, you have the patient show you his palm with his knuckles up and fingers pointing towards the floor. If you see scissoring of the digit or abnormal alignment, chances are your patient will need more than just your closed reduction. Let's talk about your most important digit, your thumb. Even if you had your hand blown up by an explosive, and if you maintain the use of your thumb, you still have a functioning hand. So, injuries to the thumb need special attention. The thumb has both a radial collateral ligament running on the lateral aspect of the first metacarpal and an ulnar collateral ligament running on the medial aspect of the thumb in anatomic position. Gamekeeper's thumb is an injury to the ulnar collateral ligament of the thumb. It's another bougie term. The gamekeeper of a large manor or estate was in charge of the game, conies or hares and rabbits and such. It was his job to dispatch them or to wring their little bunny necks. If you do this day in and day out, you'll stress out your collateral ligament and potentially rupture it. Since we're nicer to little bunnies these days, it's more common as a skiing injury. In fact, gamekeeper's thumb is also called skier's thumb. Maybe the skier stops abruptly and the ski pole handle can hyperabduct the thumb. Or maybe the patient falls on an outstretched thumb. A foost. It causes injury to the ulnar collateral ligament. X-rays may show an avulsion fracture, but not necessarily. We have to test clinically. There are two portions of the ulnar collateral ligament: the ligament proper and the accessory ligament. So we have to test each separately. We are going to apply abductive force to the first metacarpal with the metacarpal in flexion and in extension. With the thumb metacarpal phalangeal joint in extension, we then abduct the thumb. This tests the accessory ulnar collateral ligament. With the thumb metacarpal phalangeal joint in flexion, we can abduct again, and this will test for the ulnar collateral ligament proper. If you can abduct more than 15 to 20 degrees, there's laxity in the ligament, and we have to make sure that we compare to the other side to make sure that this isn't just the patient. You may have to do a nerve block because this is going to be painful. If there's laxity of either of them of 30 degrees or more, you most certainly have a rupture of your ulnar collateral ligament. What to do? If there's no avulsion fracture, then thumb spica splint and referral. If there's an associated avulsion fracture, then even more prompt follow-up is needed. The pearl here is to suspect an ulnar collateral ligament injury even with normal x-rays. Do those maneuvers to find out whether there's laxity or not. You can treat it similarly to a scaphoid fracture. You may not see anything on films, but you'll have to immobilize and preserve that function and prevent disability of your most important digit. Now we get down to some business. Fractures of the base of the thumb. There are two main types, Bennett and Rolando. With either of these, you'll see pain and swelling at the base of the thumb. After an axial load, the base of the thumb is fractured. A Bennett's fracture is an intra-articular fracture, the base of the first metacarpal as it articulates with the trapezium. Remember, trapezium is at the base of the thumb. The fracture fragment is pulled away to the ulnar side, leaving the thumb to sublux radially. On films, you'll see a broken base of the thumb with subluxation. You may need to get the so-called true laterals and an AP view of the thumb. A true AP of the thumb is called Robert's view. The dorsal part of the thumb is placed on the cassette so that the hand is in an awkward hyperpronation. This way, the X-ray truly goes anterior-posterior. A true lateral, similarly, is the X-ray machine beam pointed at an angle to overcome the thumb's natural inward orientation. Traditionally, these were reduced and splinted, but nowadays there's usually percutaneous pinning at the very least, if not open reduction with pins and screws. A similar injury results in the Rolando fracture, which is also a fracture of the base of the first metacarpal, but it's comminuted. Classically, the Rolando fracture fragments form what looks like a Y. Rolando fractures, because they're comminuted, are even more unstable than Bennett fractures. Rolando fractures usually need open operative repair. Closed reduction with pinning is less of an option here. In other words, Bennett's is bad, a medial fracture with lateral subluxation. But Rolando's is really bad, a comminuted Y-shaped fracture that pretty much always needs open surgery. Okay, I know that was a lot of theater of the mind. The show notes are there for your visuals. Just remember, in general, hand injuries are high risk, not so much for what you're going to do in the ED, but for the follow-up and the plan from there. A meticulous exam, proper x-rays, good documentation, and close collaboration with your specialist are all the watchwords here. Most of the time, we won't be the last person that this patient sees for this injury. Even if you feel that this is probably a strain, close follow-up within a few days is important, not to miss the beginning of what can end up a disabling injury. As we mentioned, the actual treatment depends on the injured finger, but these concepts will carry us through even in the toughest of presentations. Thank you for listening. And until next time, remember, you are the champion for the child in front of you. Take care.
Thank you for listening to The Playbook. We welcome your comments, questions, and feedback. Email Tim at coach@pemplaybook.org or drop by our website for show notes and more strategy at pemplaybook.org. See you there.